This case was referred to us, was operated elsewhere for a glaucoma valve, and this patient was going into corneal decompensation. And the patient came to us, and we saw there is a huge, approximately 8 to 9 millimeters of protruding glaucoma valve tubing into the anterior chamber. This patient was aphakic, and as you will notice that even with blinking movements, this tubing has a lot of movement and is very mobile into the anterior chamber, and it was touching the endothelium, especially in the inferior nasal part. Once we inflate the anterior chamber, you will notice even with these blinking movements, the tube is mobile inside the anterior chamber. So we need to trim this tube. So what we do is first we use a micro 23 gauge forceps. We put one flange of the forceps within the lumen of the tube, and with the other flange hold the outer lumen, thus holding the tube with a very tight grasp. This has to be done very carefully because if you don't have a tight grasp on the tubing, after you cut, you could lose the tubing to the vitreous or to the posterior part of the eye. Now we instill viscoelastic to ensure that the tubing or the instrument while cutting does not hurt the endothelium. Now I first attempt to cut the tube with MVR. You will notice that MVR is not cutting the tube, but instead it's pulling the tube still downwards and pulling it from the insertion area in the sclera. So I am afraid that I might dislodge the valve again. I might pull the valve downwards. So I instill viscoelastic again, hold the tube with one flange in the lumen, another flange outside, enlarge the wound because now I want to use a micro scissors or a Vana forceps or Vana scissors to trim this tube. Now, once viscoelastic has been instilled in the cornea, I coat the endothelium, again hold the tube very carefully with the 23 gauge micro forceps. Once I have a good grasp on the tube, then I proceed by introducing the micro Vana scissors into the anterior chamber and very carefully, avoiding to hit the endothelium, I trim the tube. You have to be very careful while doing that so that there's no traction either on the scleral side or on the side of the forceps. Otherwise, you can end up pulling the tube from the grasping forceps and lose the cut edge into the vitreous. Now we instill some BSS into the anterior chamber to see whether the tubing is being cut to the right dimension or not. Before I do that, I try and push the tube back into its place because I presume that while cutting the tube, I might have pulled it slightly from its insertion. To my satisfaction, I did not actually displace the tube downwards. I try and push it upwards, and I notice that the tube is only being able to be pushed until a particular level and doesn't go beyond that, which means I can further trim this tube. Now again, I go in and you have to watch this very carefully because since this is a longer travel for the forceps, you can end up pulling the tube while trimming this, pulling it out of its insertion area, trim, and while I come out, I was in a hurry. See, I've lost that trim part. The trim part of tubing can be lost to the vitreous in this situation, so I very carefully go from the opposite side. Luckily for me, it was still lying on the iris. I hold it in the lumen and very tightly grasp it and pull it out. So I am in luck. The cut part of the tubing has been taken out. Now I hydrate the wound. I hydrate the wound and try and remove the viscoelastic by just small BSS wash and dipping the scleral lip to wash away the viscoelastic. Luckily, the eye is already a vitrectomized eye. There's no vitreous in the anterior chamber. You will notice that I'm able to wash out some viscoelastic fluid which is there still in the anterior chamber. And as by the time I'm finishing, you realize that the cornea has already started becoming clear. Now, the only thing is that this eye is already hypotonic. Now, what I would do is that I would want to suture the eye before I do it. Before I proceed, I just remove the incarcerated iris into the wound, which was probably left incarcerated during the earlier surgery, wherever he was operated. Now I proceed to suture the 2.8 millimeter port which I made to use the 1 hour forceps. I will make sure that this wound is tight and secure. And after suturing this particular wound, we will hydrate the inferior part of the side port. So the main wound is sutured in this particular case. I may not normally have to suture a 2.8 millimeter wound. But since this is a hypotonic eye, I don't want to take any chances. And this patient did very well. The cornea cleared after a week, totally with no kind of opacification or no edema in the eye. So I hydrate the side port, and you will notice that now I've been able to build up some pressure in the eye, and the cornea also started clearing up. Hydration of the side port, suturing of the main wound, cutting of the tubing, and correction of the iris incarceration into the wound. All these things have been done in the case, and the patient did well. Thank you.